Thank you very much for the opportunity to present our results of this propensity score matrix analysis about pure laparoscopic versus hand-assisted liver surgery for segments 7 and 8. As you know, lesions located in segments 7 and 8 are considered to be of greater technical complexity due to the low angle available for their approach in relation to the right costal arc and the diaphragm, need to mobilize the liver, difficulty in obtaining a good surgical margin, long surgical time, and the high risk of bleeding and the higher rate of Pringle maneuver. For this reason, some authors, in order to avoid these difficulties, use hand-assisted laparoscopic surgery or the IRA technique, especially in the initial series. Another advantage of HALS, pointed out by some authors, is better liver staging by being able to palpate the liver, especially in patients with colorectal liver metastasis. In addition, HALS could be useful in the learning cube or in certain situations, especially with technical difficulties or complications. However, the use of HALS implies that an incision must be made to insert the hand, which is generally larger than the necessary to perform a pure laparoscopic approach. Technological development and the learning cube have allowed the resection of lesions located in Posterosuperior segment using pure laparoscopic approach, and in our unit, after the initial experience in HALS and pure laparoscopic surgery, we began this retrospective study with the aim of comparing the intraoperative and immediate postoperative results of both approaches in patients operated on for lesions located in segments 7 and 8. And then we performed a PCM. From January 2003 to January 2021, we exclusively included those patients with lesions located in segments 7 and 8 operated by laparoscopic liver resection in our unit. To overcome selection bias, we performed 1.1 PCM between both groups, and after PCM, 30 patients were finally included in each group. Of the 60 patients included, we compared the first 30 patients with the following 30 patients. We analyzed patient data, age, gender, children, VMA, ASA. We also analyzed diagnosis, number of lesions, size of the lesion, histology, neoadjuvant therapies, difficulty scores, interpretive data, surgical technique, blood loss, Pringle maneuver, surgical time, drains, concomitant resection, and finally postoperative data as complication, mortality, readmissions, and length of stay. HALS technique and pure laparoscopic technique, as you can see in this slide, have different trocar position. Here we have the examples of our technique, our original technique of HALS, and the technique that we use for the pure laparoscopic approach. For the PCM, we include age, gender, ASA, neoadjuvant chemotherapy, number of metastases, size of metastasis, difficulty score index, type of anatomical resection, and concomitant resection. Before the PCM, we found statistical significant differences regarding the gender. Weight for the tumor size was higher in the HALS group comparing to the pure laparoscopic group. We also find more colorectal liver metastasis in hand-assisted liver surgery and more pure laparoscopic surgery of HCC. The tumor size, as I commented, was also higher in the HALS group, and liver histology was normal in a higher rate in HALS group, and cirrhosis was higher in the pure laparoscopic group, related with the higher percentage of colorectal liver metastasis in HALS and HCC in pure laparoscopic group. There were also differences regarding the generates because in the pure laparoscopic group we use less generates, because in the last years we do more pure laparoscopic and we don't use grenade for laparoscopic resections, and postoperative stay was also less in the pure laparoscopic group with a significant statistical differences. After the PCM, we have less differences, as is logical, but we have differences regarding weight, but it's very scarce. As you can see, there was 5 for HARS and 6 for laparoscopic group, and there was also less drenate for the same reason as we commented before, and again we have less postoperative length of stay, hospital stay, 1 day. But it's important that we don't have differences regarding operative time, blood losses, critical maneuver, clamping time, global mobility, and Claventino 3A complications. So the interoperative outcomes are similar between pure and hand-assisted laparoscopic surgery group. We also compare the evolution of minimally invasive surgery in this segment in our unit, corresponding to the first and second half of the series after PCM, the first 30 cases with the following 30 patients. We only found differences regarding age. Tumor size was higher in the first 30 cases because we use more hand-assisted laparoscopic surgery, and there were also differences regarding surgical approach because in the second half of the series we use more pure laparoscopic surgery, so we have 83% of the pure laparoscopic approaches. There were differences regarding clamping time, was higher in the pure laparoscopic group, as we said before. So in the second half, because we perform more pure laparoscopy, we have more clamping time. And something similar happened with postoperative stay, that it was also less in the second half of our series. Finally, we can say in this slide that we have a little increase of the pure laparoscopy approach. We start with the hand-assisted, but little by little we increase our pure laparoscopic approach, and in the last year we only perform for segments 7 and 8 pure laparoscopic approach. So this is something that reflects that if you have a good learning curve, then the pure laparoscopic approach can be safely and is easy to perform if you have a good teachers and if you have a good experience. Regarding the other variables as surgical time, clinical time, the losses, and the difficulty risk scores are similar regarding both approaches, as we said before. So for the conclusions, we have that pure laparoscopic surgery presents similar intraoperative and postoperative results with less statistical significant differences regarding hospital stay compared to house. Centers with experience in laparoscopic liver resection can perform pure laparoscopic approach with a safely way in this segment, and HALS maybe is useful in isolated cases as a primary step before converting to open surgery, frame adhesions, bleeding, large tumors, or for groups with less experience in laparoscopic surgery as a support during selected moments of the surgery. So we would like to say thank you again for the opportunity to present our results and to congratulate for the organizers of this virtual meeting. Thank you very much.